It is advisable to study the appropriate essential anatomy as outlined in the Primer of Regional Anesthesia Anatomy before studying this block. Like the single injection, infraclavicular block is the mainstay of hand, wrist, forearm, and elbow surgery. The single injection popliteal approach to the sciatic nerve is the mainstay of foot and ankle surgery. If it is combined with a block of the saphenous branch of the femoral nerve at the ankle level, or a femoral nerve block, this block is indicated for all foot and ankle surgery. Although this block can last up to 24 or even 36 hours, it is advisable to place a catheter for continuous nerve block for longer use in case of more major surgery, such as triple arthrodesis of the ankle, ankle fusion, or ankle replacement. In such instances, it is almost always necessary to place a continuous femoral nerve block as well. The sciatic nerve innervates the lateral aspect of the lower leg, the lateral part of the ankle, and the entire foot with the exception of the medial part, which is innervated by the saphenous branch of the femoral nerve. Almost all local anesthetic agents and combinations have been used for this block. The preference of this author is to use 15 to 40 milliliters of ropivacaine 0.5 to 0.75% or 15 to 40 milliliters of bupivacaine 0.5%. The duration of the block can be extended by a factor of 3 if 0.3 milligrams buprenorphine is added to 20 to 40 milliliters of 0.5% ropivacaine or bupivacaine. It should be obvious that if long-lasting local anesthetic agents are used, the possible complications of this block will also be long-lasting. It is, therefore, advisable to rather place a catheter for continuous nerve block should a long-lasting block be required. The patient is placed in the prone position with the knee slightly flexed. The tendons of the biceps femoris and the semimembranous muscles are palpated and marked. These tendons usually meet to form the apex of a triangle of which the basis is the skin crease behind the knees. A line perpendicular to the baseline of the triangle is dropped from the apex of the triangle, and needle entry is slightly lateral of this line, 7 to 9 centimeters above the crease. The skin and subcutaneous tissue is anesthetized after skin disinfection. A 22-gauge 50 to 100 millimeter stimulating needle with a B bevel is attached to a nerve stimulator set at an output of 1.0 to 1.5 milliamps, 2 Hz frequency, and a pulse width of 100 to 300 microseconds. The needle enters perpendicular to the skin and is advanced anteriorly until the sciatic nerve is encountered. Brisk plantar flexion twitches of the foot indicate that the tibial component of the sciatic nerve is being stimulated. The current of the nerve stimulator is turned down until brisk twitches can still be observed at a nerve stimulator output of 0.3 to 0.5 milliamps. If the muscle twitches are still brisk at less than 0.2 milliamps, it probably indicates intraneural needle placement, and the needle should probably be withdrawn slightly. Eversion of the foot is when the common peroneal fibers of the sciatic nerve are stimulated. Local anesthetic agent or any other electrically conducting fluid, such as normal saline, as in this demonstration, can be injected and the muscle twitches will stop immediately. This gives final assurance that the block will be successful.